Okay, I think we're getting the hang of it, that when I have an overall arching name, I have many different types of medications that act under this overarching umbrella. So within my coagulation modifiers, predominantly, there's one, all of these are going to help my blood to not clot as easily. So we're going to do that based on three different groups of medications. And these are right in my key terms also. So in my key terms, the first group, we're going to have our anticoagulants, and they do exactly that. They inhibit the ability to form clot factors, so it's going to inhibit those clotting factors from forming, or the action of those clot factors, so it's going to keep you from coagulating. Antiplatelets, and they're going to prevent platelet plugs from forming or prevent the aggregation. Think aggregation is like clumping of platelet plugs. Or thrombolytics, which are actually lyse the clots that have been formed. So this would be, I think of this as like Pac-Man. They eat the clots that are already formed, and then our antifibrillinic will be last. So if we look at our first one, let's go back over here. What we're trying to do with these medications, they prevent the formation of, my first group, prevent the formation of clots by inhibiting certain clotting factors. These drugs have no direct effect on the blood clot that is already formed. They prevent intravascular thrombosis by decreasing the blood coagulability. I think of stickiness almost, the blood coagulability, the ability to clump together. Their uses vary from preventing clot formation to preventing the extension of an already established clot or thrombus. We always stop and question if a patient has an order for two different types of two different coagulants. So always, that's like a clinical pearl, so remember that one. These work to prevent the formation, let me scroll down. These work to prevent the formation of a clot or thrombus. The prevention of that clot is called the thrombosis. All anticoagulants work somewhere in that clotting cascade, but they do so at different points. I'm not going to ask you about the clotting cascade, but know that this has to happen to tell that to happen, to tell that to happen, to tell that to happen. So they'll work somewhere on here by interrupting that cascade. Overall effects of heparin, which is specifically, is that it turns off this entire coagulation pathway and it prevents clots from forming. However, heparin specifically cannot lyse or eat a clot in and of itself. Here's the overview. And then if I get down to here, scroll down a little bit. My indications for these are to prevent clot formation, which is a benefit of certain settings, especially if there's a high likelihood of clot formation. They're used to prevent and treat clots. They're used as for DVT prophylaxis. So think about someone who's going to be bedfast for a bit. That might be prophylaxis for that. And the term bridge therapy refers to the fact that enoxaparin acts as a bridge to provide anticoagulation while the patient must be weaned off of warfarin therapy. So sometimes we'll start one medication while they're in the hospital, and then we'll start the medication that they're going to go home on at the same time, and we'll be weaning them off the medication in the hospital so that they can continue the medication at home, or vice versa. Our contraindications for these are going to be acute bleeding. So if they've got an acute bleeding process, obviously, or a drug allergy, or a high risk for bleeding, then they would be contraindication for those individuals. Adverse effects range from bleeding, which is the main complication of any anticoagulation therapy, and the risk increases with increasing dosages. So the higher their dosage level, the more likely they are to have unintentional bleeding. We can also have heparin-induced thrombocytopenia, which is here where you actually deplete their ability to clot and they bleed out. We can have type 1 or type 2 thrombosis that occur in the presence of this heparin-induced thrombocytopenia that can be fatal. It's fairly rare, between 5 and 15%. I've seen it twice in my practice, so not a ton of times. Good table right here, 26.2, that shows you a lot of the adverse effects. Notice the first one on all of them are bleeding, and then you'll see hematoma comes up shortly on the second one. Although the toxic effect of all our anticoagulants are hemorrhagic, meaning too much bleeding, the management is different for each of the drugs. So symptoms of hemorrhagic effects would be hematuria, so blood in your stool, blood in your melena, blood in your stool, hematuria, blood in your urine, petechiae or ecchymosis, so bruising, bleeding of the gums or the mucosal membrane. In the event of bleeding that can't be stopped, then the drug must be stopped immediately. I'll come back to one particular drug in just a second. Then I also wanted to show you table 26.3 because it shows us a lot of interactions. Enzyme inhibition inhibits a lot of the metabolism of these medications. We can actually also have displacement of the drug from inactive protein binding sites. We can also causes decrease in vitamin K absorption or synthesis because of the natural flora in the gut, and it can cause alteration in platelet counts or activities. Under this one, we have 3 different medications. Let's look at those. My first drug of choice for my anticoagulants is enoxaparin. On my enoxaparin, I want you to note that the antidote for this is protamine sulfate. It's a 1 milligram to 1 milligram institute. So I would give 1 milligram for every 1 milligram over of this one. This is a common one that we'll give prophylactically or in the hospital. We always want to question if our patient has 2 anticoagulants, so Lovenox and like heparin would be the next one, which we'll get to. Enoxaparin comes to us in a pre-filled syringe, and it specifically says that there's an air bubble that we don't expel from the pre-filled syringe because that air bubble helps to hold the medication in place when it's in the subcu tissue. My next drug, which we'll give more frequently, you'll give as frequent in the hospital, is heparin. On my heparin, we use this one predominantly for DVT prophylaxis on our patient, which would be 5,000 units 2 to 3 times a day given subcutaneously, usually given in the abdomen. We usually have a weight-based protocol for that administration, so we'll have to know my patient's weight and then give their heparin according to that. We also want to make sure we're monitoring their bleeding time. Specifically for heparin, it's an APTT, which is the activated partial thromboplastin time. We most commonly use it for that DVT prophylaxis. If we are giving it through continuous IV infusion, that's when I'll monitor that PTT, and I will increase or decrease my heparin dependent upon that PTT reading. So whatever that reading is will determine if I need to go up or down or titrate up or down on their heparin level. Let's see, my next one in this one is Coumadin or warfarin. So warfarin's the last one. This is an oral medication. My antidote for warfarin is vitamin K. So on my warfarin, this is PO. It works by inhibiting that vitamin K synthesis in the gut, which inhibits the production of clotting factors. As with heparin, the final effect is the prevention of clot formation. It's available in oral form. It requires careful monitoring of the prothrombin time and the international normalized ratio, which is an INR. On the INR, that's that standardized measure that tells us the patient's blood coagulability. A normal INR without warfarin is about a 1. When it's therapeutic with warfarin, we want that patient to be about 2 to 3.5, depending on where they are with that, depending on where they should be. If they have an artificial heart valve, that might be higher than that. It might go up just a little bit more, but usually we'll keep it between 2 and 3.5. Because my warfarin inhibits vitamin K dependent clotting factors, foods that are high in vitamin K may reduce my warfarin's ability to prevent clots. So think about common foods that are rich in vitamin K, such as green leafy vegetables, kale, spinach, collard greens. And the most important aspect of the food to drug interactions is consistency in diet. So if they've always eaten that food, then that's fine, but we don't want them to all of a sudden, if they haven't eaten that food, to start eating it all of a sudden. So an NCLEX question would have 4 different types of trays or dinner, and they'd want you to avoid the one that has an increase in the vitamin K food. My next group of drugs are my antiplatelet drugs, and they do exactly that. They prevent platelet formation. I've got, scroll on that one, on my platelet formation. They usually work at the site of a blood vessel injury, and it can that occurs before the clotting cascade actually happens. So it breaks up that cascade by prohibiting where that vessel wall has my injury. My indications for this is I want you to think of aspirin as the officially recommended by the American Heart Society for stroke prevention in doses anywhere from 50 to 325 milligrams. The most common doses is that 81 milligrams a day. We used to call that a baby aspirin. Now we call it 81 milligram a day. Our medication, another medication that we use in addition to aspirin for this one is clopidogrel. And it's given to reduce the risk of thrombotic stroke or for prophylaxis against TIAs, that transient ischemic attacks, as well as post-MI, after an MI, to prevent a thrombosis. Let's see. My contraindications for these medications would be drug allergies, if they have any active bleeding, if they have leukemia, gastrointestinal ulcer, vitamin K deficiency, or recent strokes would put them at contraindication. Adverse effects, all of them pose a risk for bleeding, so pay attention to that. And there's a nice table, 26.4, that shows you a lot of the adverse effects that are associated with antiplatelets, as well as some interactions. Interactions being additive antiplatelet activity and increased bleeding potential, especially with some medications such as NSAIDs, and NSAID would be like ibuprofen, increase the ulcerogenic effects of aspirin. So if you think about aspirin, most aspirins that we see in the 81 milligrams are enteric coated because we don't want them to start to lay on the stomach wall and eat into that stomach mucosa. So if they're coated, it will prevent that ulcer from occurring. But if I take something else like an NSAID with it, it can cause ulceration to occur.